According to UNITAID, 25 million deaths annually are attributed to conditions where medical oxygen is needed but not available. These include deaths due to childhood pneumonia, preterm birth, neonatal asphyxiation, and postpartum hemorrhage. In low-resource settings, only 1 in 5 children who need life-saving oxygen treatment receive it.
My name is Hilda Bujingo, AFHIA 2 project engineer. My sister, who gave birth to premature twins, and unfortunately, there was not enough oxygen at the hospital she was admitted. So we lost these babies in a time period of 2 days, where the babies were on oxygen, but it was not sufficient to sustain their lives. So it is quite important to have these little ones have oxygen, timely oxygen, and also to reduce the challenges or the disabilities that may come with a lack of oxygen. Most of the health workers we are meeting or we have met, they talk about failure of oxygen concentrators and they are dumped into the equipment graveyard of the hospital.
Traditionally, hospitals and clinics have had to purchase expensive equipment upfront, only to face challenges because they don't have the capacity to repair and maintain the equipment, they are burdened by unpredictable supply chains and costs, healthcare workers are unsure how to use the equipment, and they struggle to increase their oxygen provision in times of high demand, such as health, climate, or conflict emergency. These service-based models shift the responsibility of equipment ownership and maintenance from healthcare facilities to specialized providers, ensuring a continuous and cost-effective oxygen supply. This frees up healthcare providers to focus on delivering high-quality care rather than rationing oxygen supplies.
We had that problem of oxygen supply, especially when we are having breakages of these oxygen concentrators. Also, at regional referral hospitals, we are facing a lot of problems in getting those oxygen cylinders because previously we were getting a lot of death.
These tragedies could have been prevented if local health facilities had reliable access to medical oxygen. At the Oxygen CoLab, we have been supporting a group of oxygen providers who are pioneering oxygen as a service in different places. These oxygen as a service models include oxygen equipment such as concentrators, PSA plants, and pulse oximeters, consumables, backup oxygen supply for use during power disruptions, ongoing repair and maintenance to ensure reliability of equipment, comprehensive training to empower healthcare workers with the skills to diagnose the need for oxygen and administer it safely and effectively, a flexible and affordable package that works for that facility, whether they're big or small, well supplied with equipment or without. If every local health facility had oxygen as a service, they would all have access to uninterrupted and reliable supply of oxygen. And we've seen it work. Our early projects in Nigeria, Uganda, Kenya, India, and Tanzania have led to more consistent oxygen availability, better patient care, and more predictable costs. It's a model that's both effective and also has potential to be sustainable in the long run.
In Nigeria, 90% of health facilities struggle with unreliable oxygen supply, frequent power outage, and high cost of maintaining equipment. At Healthport, we are testing a different approach. We are providing tailored solutions to facilities through on-site solar-powered oxygen generation for high-volume facilities and the hub and spoke cylinder distribution model for smaller facilities.
Oxygen as a service is a kind of plug-and-play service model that whenever any of our partner facilities sign on, we take care of all their oxygen need from production, distribution, training, and data management.
From zero, we've done piping of almost 200 piping to bed, which is in the oxygen space for distribution, that is a massive leap.
With us, facilities pay a fixed monthly fee or per cylinder usage, removing upfront costs and shifting maintenance to the service provider. Each of our packages will include oxygen piping where necessary, backup storage, pulse oximeters, and predictive data management to track and optimize supply. We also do include on-site clinical support and biomedical guidance. A year ago, oxygen shortages meant hospitals could only meet 10% of their demand. Today, across Healthport partner facilities, oxygen is available 100% of the time, even when demand surges. Where it once took 15 minutes to get oxygen to a patient's bedside, it now takes less than 1. The delays caused by moving and switching cylinders are completely gone. At approximately $1.64 per cubic meter, the cost of oxygen has nearly halved compared to the market average, making it more affordable for facilities that need it most. Along the way, 79 healthcare workers have been trained, 10 facilities are now part of the model, and over 1,000 patients have received oxygen as part of their treatment. Step by step, this is what it looks like to test, refine, and build towards better oxygen access. Demand is growing, more facilities are joining, and expansion into Nigeria's South-South region is underway. The focus now is on scaling what works and refining the model to meet the needs of more patients and healthcare providers.
FREO2 is piloting its Oxygen as a Service model in rural health facilities across Tanzania, Uganda, and the Solomons Islands. The hospitals often struggle with oxygen shortages due to power outages, high costs, and unreliable equipment. Our approach provides hospitals with oxygen concentrators, power stabilizers, and a prioritizer which automatically switches to backup cylinders during power outages and pulse oximeters. Installation around the clock monitoring and staff training help ensures smooth operation, while a swap and go maintenance system quickly replace or repair faulty equipment to prevent disruptions. During a 3-month trial in Uganda, a hospital faced 215 power outages, yet oxygen never ran out. FREO2 system kept it flowing. Switching to FREO2 model has cut cost by 71%, from $1,500 to $439 per quarter. In pediatric ward, the cost of treating respiratory illness has dropped by 30%, making more affordable.
In terms of cost, it has helped the facility, especially on maintenance of oxygen concentrators. They no longer break down like previously because they were overworked.
Kipindi cha nyuma pia tulikuwa tuna changamoto za umeme kukatika. Umeme ukikatika, hatuna backup ya concentrator, unakuta mitungi ya wakati huo haipo. Lakini kwa sasa hivi hatuna changamoto hiyo tena. Tuna mitungi ambayo inahudumia watoto 4 kwa wakati mmoja. Kipindi cha nyuma tulikuwa na mtungi mmoja, labda concentrator moja inatumika na maeneo mengine. Lakini kwa sasa hivi tuna hiyo free oxygen inahudumia watoto 4 kwa wakati mmoja. Kwa sasa hatuna changamoto. Kwa tunatamani tuongezewe zaidi, ili basi maana hospitali yetu inaendelea kukua, ni hospitali ya wilaya.
The most overlooked issue in oxygen access is maintenance. We employ a model called swap and go, where when we get to a facility, identify a major issue like a concentrator failure, stabilizer failure, we replace the failed equipment with a new one, and then we work on the failed one at the hub. So this has enabled operation of the FREO2 oxygen systems on time and less downtime, which is a major hindrance in oxygen access.
We have been able to train over 400 clinical personnel on how they can diagnose but also prescribe oxygen as a treatment. And I'm proud to say these have been great towards addressing the needs of medical oxygen and making sure we are addressing the gaps or the demand that's already existing.
Our model is built around the O2 tube, which is a solar-powered system that fills oxygen cylinders using concentrators. So the cylinders are then distributed to hospitals and the clinics through the hub and spoke system. So this means that instead of every facility generating its own oxygen, a central hub like AFHIA fills and supplies cylinders to multiple surrounding clinics and hospitals. And this approach, actually what we have realized, that it makes delivery more efficient and ensures that small facilities and hospitals can still access oxygen with a reliable supply. While awaiting approval for the O2 tube by the Uganda National Drugs Authority, we launched an oxygen kickstart program, sourcing cylinders from joint medical stores, which is in Mbarara, to keep facilities supplied in the interim. Hospitals pay per cylinder, with the cost covering oxygen supply and clinical training for their healthcare workers. So by removing the burden of equipment ownership and maintenance, the model is exploring simpler and more sustainable oxygen access.
If I was to say one message to decision makers within the oxygen space, I would say let's invest on people and let's invest on technology. Because what I've learned over the years is that having smart solutions is key towards addressing oxygen deficiency which is existing in the facilities. And also having reliable people who can do that is even important. Because what we learned is that we still need more biomedical engineers or technicians in the facilities in order to ensure these facilities do not have graveyard of oxygen services equipments, but having reliable and operational oxygen equipment is key towards making those great demands.
At the Oxygen CoLab, we believe that this, at its core, is about reshaping how health facilities provide critical care, so that facilities move from living with uncertainty about their oxygen supply to having confidence in their ability to provide high-quality treatment to their community. It's about ensuring that every clinician can focus on care instead of logistics. It's about ensuring that communities can trust their health facilities to be ready when it matters most. We hope that in the near future, we will see successful oxygen-as-a-service suppliers translate their offerings into new regions, and more local enterprises emerging to also deliver these life-saving oxygen services. Experience so far tells us that innovation and growth is enabled through partnerships. That is why we are working with businesses, health facilities, governments, and investors to build towards this better future. If you share this vision, we invite you to join us in making reliable oxygen access a reality for all.